Thank you to give me the opportunity to talk about the Glenoid B2, advantage of a preoperative planning with the software. This is my disclosure. The first is to define the Glenoid B. And Valch did a very nice classification. B is defined with a retroversion of the glenoid and the posterior subluxation of the humeral head. You have B1. There is posterior arthritis with a posterior subluxation of the humeral head. B2 with a B concavity with arthritis, and B3 with a unique concavity with more retroversion. So it's not so rare, and Gilles described B2 between 70% to 27% of this case. And in my personal series of 133 anatomic total shoulder arthroplasty, I had 20 cases of Glenoid B2, 16%. So in front of arthritis with big glenoid, you have many therapeutic options. You have conservative treatment, arthroscopic debridement, biological interposition by arthroscopy, glenoid osteotomy, hemiarthroplasty, rim and run, glenohumeral arthrodesis. And today, we will talk about the indication of anatomic and reverse total shoulder arthroplasty. So in the Glenoid B1, mostly we use anatomic total arthroplasty. We don't change the retroversion. Retroversion 5 or 10 degrees is acceptable. We try to reproduce a good balance of the muscle, a joint line, on the lateral offset. If you have a Glenoid B2, this is a big discussion today between anatomic total shoulder arthroplasty or reverse arthroplasty. If you use anatomic, you have more range of motion, more external rotation. If you use reverse arthroplasty, you have less complication and less revision. Probably if you use anatomic, it's most reliable operation in terms of pain, relief, and range of motion. So we have 37% of glenoid loosening at 10 years. And in B2 or B3, you have a high failure rates with early glenoid loosening, sometimes after 2 or 3 years. And more important, you have a recurrent posterior subluxation of the humeral head with a risk of glenoid loosening. So if you use anatomic total shoulder arthroplasty in B2 and B3, you have a risk of glenoid loosening, posterior subluxation, humeral loosening, and polyethylene wear. So if you decide to do anatomic in B2, you have to correct the retroversion, you have to correct the inclination, and you have to correct the posterior subluxation of the humeral head. And the best positioning of the prosthesis should be to reproduce anatomic position of the articular line, the center of rotation, and the perfect lateral offset to obtain a good balance of the muscles. So, how do you manage the posterior glenoid defect? If the retroversion is less than 15 degrees, we can do asymmetric rimming, and you put a small polyethylene cementing or metal back. If you have retroversion more than 15 degrees, the tendency today is to use a polyethylene augmented or a metal back with bone graft. The way is to use a metal bar convertible, and if you have a complication of anatomic, you shift to reverse without removing the glenoid component. So this is an example of a patient of 51 years old, osteoarthritis, posterior subluxation of the humeral head, very painful, but acceptable range of motion. And you see that the CT scan, you have a retroversion of 23 degrees. You have a posterior subluxation more than 80%. This is a glenoid B2. And the curve is functional. You do MRI, you do CT scan with a T1. And I did a anatomic arthroplasty, metal back. And this is the results that we obtained with more than 2 years follow-up. a perfect anatomic reconstruction of the shoulder with a complete range of motion in external rotation and in medial rotation. So in this case, if you have any problem with the metal back, you can shift to the reverse without any removal of the stem or the glenoid component. Regarding the Glenoid B3, we use a reverse arthroplasty. Even the cuff is functional because if deformity is too important, the posterior superior humeral head is more than 80%, and the retroversion is more than 25 degrees, and reverse is my choice. So this is a salvage operation, probably the best option. And sometimes we have some complication in young patients, but this technique is reliable regarding the pain relief on the range of motion, because if the cuff is functional, this prosthesis is working on the cuff with the deltoid. So now the question is, do you use a preoperative planning with a software, eOrtho? Yes, systematically. It's very useful for the education of the young surgeon, and is very useful to reproduce the better positioning of the glenoid component in the glenoid. So with the software, we evaluate the status of the cuff on the deltoid. We evaluate the inclination, the version, the medialization, the degree of posterior subluxation of the humeral head. And we choose with this software the type of the glenoid component. We use a guide, we measure the distance, and we can reproduce an inferior tilt for the reverse between 0 to 10 degrees, a retroversion acceptable 0 to 10 degrees, on lateralization and distalization. So we can measure with the eOrtho software the good positioning of the component. This is an example of a male, 45 years old. He was painter. He was very painful with a limited range of motion on a function of 30. So you see that 90 degrees of elevation, a little external rotation, 20 degrees, medial rotation, limited. So this is a CT scan, and you see that there is a posterior subluxation, posterior erosion, glenoid maybe B3 or 2, and no cartilage. It's on the cuff is functional. So we use a software, eOrtho 3D, and we have an axial plane, coronal plane, and we have a reconstruction in 3D dimension. And we have the information regarding the retroversion, 24 degrees of retroversion, 68% of posterior subluxation, and 7 degrees of inclination. And we know that if we have to do a reverse, we have to correct retroversion, inclination, and posterior subluxation. So with this software, we choose the guide to correct version and inclination. For example, we use this guide with a posterior compensation, and we correct the native retroversion 24 degrees to 8 degrees of retroversion. And with a guide for the inclination, this is the same guide. We use a Kirchner wire in the center of the glenoid in 10 degrees of inclination to correct the native 7 degrees superiorly to 9 degrees inferiorly. With this software on this guide, we can reproduce the preoperative planning for the reverse or for the anatomic arthroplasty. So this is the result of this patient. You see that he's very young. You have a complete range of motion. We have reproduced the inferior tilt, lateralization, and distalization, and we have a perfect external rotation on the right side, and you have a complete forward elevation, external rotation in position 2, on internal rotation 1. So an excellent result of a reverse with the functional cuff on glenoid B3. My first conclusion is that the software eOrtho is very useful and we use systematically for all the protheses, anatomic or reverse, to reproduce because we prove that this software is reliable and increase the precision of my implantation of the prosthesis. So we can define the inclination, version, medialization of the glenoid, the type of the glenoid implant, the degree of inferior tweed, retroversion, and lateralization. So now we implant the prosthesis depends on the status of the cuff. If we have no posterior superior cuff, like a cuff teratopathy with a weak deltoid, we prefer to distalize the prosthesis and we lateralize less. If we have a strong deltoid with a cuff deficiency, we prefer to lateralize more than distalize. And if you have a old man, 80 years old, with a good deltoid, with a cuff functional, we prefer to lateralize and distalize. So the last conclusion is that now, in my practice, when I have a B1 glenoid, I try to reproduce the anatomy with the anatomic arthroplasty, and I use a dual platform system to facilitate the conversion to reverse. In B3 glenoid, we prefer reverse arthroplasty. The discussion is regarding B2 glenoid. Anatomic arthroplasty, we can use a polyethylene augmented or metal back with a bone reconstruction. Or if you are afraid regarding the rate of revision, you can use a reverse arthroplasty. Thank you a lot for your attention. Muchas gracias.